Hi, my name is Luis Gude. I'm currently a fourth-year medical student at the University of Buffalo, the Jacobs School of Medicine, and I'm here to talk to you guys about an interesting case that we came across in my diagnostic radiology course. So the patient's a 39-year-old white male. He presents with a chief complaint of right ankle pain that he reports began after a motor vehicle collision in July of 2016 where he rear-ended a truck that entered his lane. The airbags were deployed, and the patient states his car was totaled. He admits to having loss of consciousness during the accident, which he regained a few seconds later. He was wearing a seatbelt. He reports that the right ankle pain was immediate. Um, it's currently a constant pain, 4 out of 10 at baseline, worsening to 10 out of 10 with any form of exertion involving the right lower extremity. He describes the pain as sharp and stabbing like a knife, and has not changed in character since the accident. After the motor vehicle collision, the patient was taken to a local hospital where he had a simple radiograph of the ankle done. He can't remember the results of the study, and it's not available to us, but he was discharged with 800 milligrams of ibuprofen. He took this medication one time. He didn't take it again because he stated it gave him nausea and didn't help with his pain at all. Besides that, he has tried heat, ice, and he went to physical therapy for 1 month in an attempt to relieve the pain, but it has had no success. Uh, he also reports that the ankle pain is interfering with his sleep. He only gets a few hours of sleep each night, and he also has complaints of numbness and tingling in the right lower extremity, starting from the back and radiating down the leg to the ankle. In this accident, he also sustained neck and back injuries for which he's being seen by a chiropractor. Other interesting parts of his history is that he um, participated in mixed martial arts for 11 years. He reports he had lots of kicking to the body. He was also struck as a pedestrian by a car in 2007, where he suffered lower back injuries as well as his right shoulder and wrist. He also has a prior MRI of the right ankle taken 1 month before the accident. He claims that this MRI was done because he had a rash on his ankle that was draining pus. We tried to get more of his medical history, but those files were not made available to us. His other medical history, he has no known food or drug allergies. He has a history of asthma, for which he uses albuterol and Advair, as well as high cholesterol, for which he takes two medications, but he's unsure of which. His surgical history is significant for four procedures for ulnar nerve entrapment. He had 2 surgeries done for each extremity. He has had bilateral carpal tunnel release, as well as a rotator cuff repair and a vasectomy. He has a 14-pack year of smoking. He denies the use of any other illicit drugs, and he has not been employed for some time, but he does have a history of working in construction, and he's not aware of any family history. On physical exam, his vitals were stable. His BMI is 34.9. Of note, in his upper extremities, there is decreased sensation to light touch in the distribution of C6 to C8, as well as decreased sensation to light touch in the lower extremities bilaterally in the distribution of L3 to S1. On exam of the ankle, the right ankle is mildly swollen compared to the left, and he also has a few areas of erythema at the right ankle, which is consistent with some sort of rash. On palpation, there was extreme pain to palpation of all parts of the ankle, the medial malleolus, the lateral, and pretty much anywhere you touch him on the foot, he jumps. Range of motion was limited in the right ankle, both in active movement and passive movement, and the movements of dorsiflexion, plantar flexion, inversion, and eversion. I also did some more specific ankle tests. The Taylor tilt test was positive with pain, and this indicates that he might have some ligamentous injury to that ankle. And the anterior draw test, which tests for ankle stability, was positive for pain, but there was no increased laxity. In addition, strength in the right lower extremity was decreased, kind of universally, including the psoas, quadriceps, hamstring, tibialis anterior, and gastroc. This is compared to full 5 out of 5 strength on the left. He stands with a cane, and when he walks, he has an obvious limp and favors his left extremity. He is unable to heel walk or toe walk, secondary to pain. And he's also unable to hop due to this pain. In workup of his back pain, electromyography was done. The results were relatively benign, but there was evidence of a right S1 radiculopathy made evident by a prolonged right tibial H reflex. So now moving on to the images that are available. This first image is a T2 weighted MRI. This was taken before the motor vehicle accident for, again, what the patient claims was ordered for a draining rash on his right lower extremity. And here we can see this osteochondral defect. It's filling with a high intensity fluid and appears to be communicating with the joint space. It can also be seen over here. Again, this is taken before the accident. It just shows the osteochondral defect. There is no evidence of any intra-articular osteochondral fragments or bony fragments. Generally, MRIs have a high sensitivity and specificity for identifying osteochondral fragments. These images were taken, again, a T2 weighted MRI, this time around 2 months or 3 months after the motor vehicle collision, and it shows that same lesion, which is very slightly increased in size. And this is the same. Okay, this is a CT that was performed after the second MRI. Again, it shows this osteochondral defect, but as we go through, there is this area of increased density, which is within the joint space and is consistent with a bone fragment. And it can be seen over here. And this is the osteochondral defect that we had been looking at the whole time. Given his history of back pain and radicular symptoms, he also had imaging done of his lumbar spine. This is taken at the level of L2 and L3, T2 weighted image, and at this level there's really no pathology, just some desiccation of the disc. As we move down the spine, this is at the level of L3, L4, which appears to be normal, with no evidence of disc herniation, canal stenosis, foraminal narrowing, or arthritic change. At the level of L4, L5, there is this desiccation with a mild bulge of the annulus. And at the level L5, S1, there is this small central disc bulge and mild facet arthropathy. So our differential for this case included osteochondritis dissecans, osteoarthritis with a subchondral cyst, a peripheral nerve entrapment, and lumbar radiculopathy. And the final diagnosis is osteoarthritis with a subchondral cyst and intra-articular fragment. This diagnosis was confirmed with a CT of the ankle, which revealed the intra-articular fragment, and the EMG that had been performed ruled out peripheral nerve entrapment, but had findings consistent with an S1 radiculopathy. But given the imaging that we have, the history taken, and the physical exam that we performed, it's unlikely that this ankle pain is due to any S1 radiculopathy. At this time, the patient, like we talked about before, the patient currently does not take any medications for pain. He has tried ibuprofen, heat, and physical therapy, but they have not been effective. He had gone to see one orthopedic surgeon who recommended surgery, but he was not an ankle specialist, so the patient has been referred to an orthopedic surgeon who does specialize in the ankle, and we're still waiting to see how his case finishes. His neck, back, and shoulder complaints are also being managed by a chiropractor. So osteochondritis, or these osteochondral lesions of the talus, were first described in 1738 by Alexander Monroe, where he reported findings of ossified cartilage within the joint space. Osteochondritis dissecans and these osteochondral lesions have a long history of confusion associated with naming them and what to call them. The first time osteochondritis dissecans was used was by Franz Koenig in 1887, where he was describing loose bodies found within joints, including the elbow, knee, ankle, and hip. He thought that these fragments formed due to inflammation, hence the name chondritis, indicating that inflammation. However, more recent studies have shown that inflammation is not the main cause of the lesion that forms, and it's considered that osteochondritis dissecans is kind of a misnomer for this type of injury. However, a report by the research in osteochondritis dissecans of the knee defined osteochondritis dissecans as a focal idiopathic alteration of subchondral bone with risk for instability and disruption of adjacent articular cartilage that may result in premature osteoarthritis. These osteochondral lesions have a classification system that was developed by Berndt and Hardy in 1959. They use radiographic findings, and they created this system with 4 stages. Stage 1 lesions have an area of intact cartilage with underlying subchondral bone compression that can normally be identified on MRI but not radiographs. Stage 2 lesions have an osteochondral fragment that's partially detached. And stage 3, these osteochondral fragments are completely detached but have not displaced, while in stage 4 lesions, the fragment has been displaced. In 2001, the system was expanded to include stage 5 lesions, which are subchondral cysts, and there are also other classification systems that use MRI, CT, and arthroscopy, but the Berndt and Hardy classification system has widely been used since its development. So the exact reason as to why these lesions form is currently unknown. It likely involves some form of trauma, either an acute injury or repetitive microtrauma, in combination with other risk factors like ankle instability, vascular insufficiency, or genetic predisposition. Lateral lesions of the talar dome are associated with trauma almost 100% of the time, while medial lesions are associated with trauma 82% of the time. And our patient has a history of repetitive microtrauma secondary to his MMA fighting, in addition to the acute trauma he sustained in the accident. And since we have imaging showing this osteochondral defect before the accident, it's likely that it formed originally secondary to his participation in the MMA style sports. Medial lesions tend to be more common than lateral lesions. Generally, the medial lesions are more posterior and central, and tend to be larger, cup-shaped, and deep. Lateral lesions are more interior, and they tend to be small and shallow, and they're also more likely to displace. Our patient has a lateral lesion with CT evidence of a calcified fragment within the joint space, and given the patient's history that this ankle pain started immediately after the accident, it's likely that the trauma he sustained caused this fragment to come loose. Like many other patients with osteochondral defects of the talus, our patient's presentation was initially nonspecific. He had complaints of diffuse ankle pain, swelling, and we found decreased strength and decreased range of motion. Ankle pain is the most common symptom reported by these patients in over 95%. And then these other symptoms, they vary from patient to patient. 15 to 49% report swelling, 8% report locking, and there's also reports of instability and decreased strength, as well as decreased range of motion. So, given that the presentation of osteochondral defects is nonspecific, the first imaging study usually ordered is a plain radiograph, looking for a fracture, and normally we get 3 views of the ankle, AP, lateral, and mortise. If an osteochondral lesion is present on the simple radiograph, it will look like possible flattening or radiolucency of the cortical surface, and as time goes on, these contour abnormalities may become more pronounced, and the area could show fragmentation with density changes, both lucency or sclerosis. So while some x-rays might be able to identify the lesion, in up to 43% of cases, it would not be able to identify an osteochondral defect. And this is because x-rays are not able to visualize non-calcified cartilaginous structure, particularly stage 1 lesions. So if an osteochondral defect is suspected, a CT or MRI would be the choice imaging modality. Generally, MRI is preferred because it allows for evaluation of the soft tissue, including stage 1 lesions with sensitivity and specificity of 96%. It's also preferred because you could evaluate other soft tissue structures like ankle ligaments. When evaluating the MRI images on T1, the osteochondral lesions and fragments are generally a variable signal. You're going to get most of your information from a T2 weighted image. On T2, the defect is normally filled with a high signal fluid, and loose bodies of osteochondral tissue would be an area of low signal surrounded by a high signal fluid. A subchondral cyst will show an edematous area on T2 weighted images. CT may be preferred in patients who can't undergo an MRI. Either they have a metallic foreign object or some sort of device like a defibrillator or pacemaker, or if you want to evaluate the lower extremity for any other bony pathology like an ankle fracture or of the tibia or fibula. CT is better compared to MRI for evaluating these osseous structures, and the findings on CT are simple to radiographs, and they're also limited by the fact that they can't evaluate the cartilaginous structures, so that ankle articular cartilage. So when we look at our patients' images, we've been through them already. We have the pre-accident MRI showing the osteochondral defect. These are post-accident MRI, and now to the CT, again showing the osteochondral defect with this fragment. Since we don't have any previous CT images of the ankle, it's hard to say whether or not this fragment existed beforehand. The fact that it's shown on CT and not the MRI is consistent with this is a calcified fragment, and it's possible that it was dislodged as a result of the motor vehicle accident. Therapy for osteochondral defects of the talus fall under two broad categories, either non-operative or surgical. Generally, the initial method of treatment is determined by the Berndt-Hardy stage of the lesion. Generally, for stage 1 and stage 2 lesions, non-operative therapies are preferred as first line, and these include bracing, immobilization of the ankle, physical therapy, oral steroids or non-steroidal anti-inflammatories, or injection of steroids. Currently, there's no real good data on the most appropriate therapy for talar osteochondral defects. There have been no randomized control trials, so a lot of the data we have has been compiled into a systematic review, and in one of these reviews it showed that conservative treatment for these lesions is about 45%, and that's across the board for each of the modalities applied. It's depending on the study, which are normally small patient populations, ranging from 15% maybe up to 55%. Patients who are candidates for surgery are those with stage 3, stage 4, and stage 5 lesions, or those who have failed conservative therapy. The surgical options are pretty broad, and the one used is usually determined by the location and the extent of the lesion. Generally, these surgical techniques have a success rate of over 70%, with newer methods approaching 95% success rate. Given our patient has this stage 5 lesion, the osteochondral cyst with an intra-articular fragment, he will likely need surgery, for which he is being referred to an orthopedic surgeon. And so that's all I have. I want to thank you for taking the time to read my case and watch this video. I hope I was able to provide some information about these types of injuries. Thank you.